Our final presentation is titled, Reducing Functional Bed Capacity Due to Boarding Predicts Increased Rates of Left Without Being Seen, presented by Dr. Yosef Berlyand at Warren Alpert Medical School of Brown University.
Good morning, everyone. On behalf of my colleagues at Brown University, I am thrilled to present our study, which shows that reduced functional bed capacity due to boarding inpatients predicts increased rates of leaving without being seen in the emergency department. We have no financial disclosures. So, why do we care about leaving without being seen? Let's start with a case to frame the discussion. Imagine a typical busy day in your emergency department. A 55-year-old man presents with chest pain. He has reassuring vital signs and a screening EKG, which shows no STEMI, so he takes a seat in your waiting room. In a few hours, you call his name, but he has left without being seen. You wonder, is he okay? We've all been there and felt that uneasy feeling. Let's discuss leaving without being seen. It's a core measure tracked by CMS, and it's on the rise. Rates of leaving without being seen have doubled across the board, and the 95th percentile of worst performing hospitals are experiencing rates of about 10%. That's 1 in 10 patients. Leaving without being seen results in poorer patient outcomes and lost revenue for hospitals. Efforts to mitigate rates of leaving without being seen have largely attempted to address internal factors through flow improvements, for example, by decreasing the length of stay of discharged patients or door-to-dock time. This is all occurring during a backdrop of an unprecedented time of crowding and inpatient boarding across our country's emergency departments. We see this issue highlighted in the popular press by emergency medicine professional organizations and in the academic literature. I have no doubt every physician in this room has personally felt the impact of boarding on their ability to provide high-quality care to our patients. And even though we feel the impact of boarding the most in the ED, it is an external factor to ED operations. There is now an AHRQ call for more research into boarding, and the Leapfrog group has announced that they're going to be collecting data on inpatient boarding. With this in mind, it's vital that we accurately measure and communicate the impact of inpatient boarding on the emergency department. Because of this need, we created a new variable called functional bed capacity. Our aim was to create a generalizable, easy-to-measure variable which can be easily understood by a non-clinician or a non-ED leader. Functional bed capacity is the percentage of ED beds, including formal hallway beds, that are available for active or new ED patients. In other words, it is the percentage of ED beds that are not occupied by an inpatient boarder. We chose to report this variable in terciles. Low functional bed capacity means a low capacity for ED patients due to a high boarder volume. The exact tercile cutoffs are going to vary from ED to ED, but on the right, you can see a graphic representation of an example of this. The blue bar represents the percentage of ED beds available for active or new ED patients, while the orange bar represents the percentage of beds occupied by inpatient boarders. Understanding this variable is not dependent on ED size, so it's generalizable across emergency departments. So we then asked, what is the relationship between functional bed capacity in the emergency department and rates of leaving without being seen? We conducted a retrospective observational study evaluating nearly 400,000 patient encounters over 20 months. We studied 3 emergency departments, a large tertiary care academic ED, a mid-sized community ED, and a pediatric ED, which are all within a single urban medical system. We collected daily operational metrics such as daily arrival volume, boarding times, rates of leaving without being seen, etc. We performed an unadjusted and adjusted quantile regression that predicted rates of leaving without being seen by functional bed capacity. We control for common covariates that are thought to be independently associated with leaving without being seen, such as daily arrival volume, length of stay of discharged patients, season, and day of the week. Here are our aggregate operational metrics across all 3 emergency departments in the study. Our median percentage of patients who left without being seen was 6%. Our median daily arrivals was 204, and our median functional bed capacity was just over 85%. Here you can see the functional bed capacity shown by site. For our academic emergency department, the functional bed capacity cutoffs for the different terciles were 73%, 81%, and 96%. As you can see, the tercile cutoffs at the community site and the pediatric ED were generally higher due to a lower inpatient boarder volume at these sites. We found that functional bed capacity in its lowest tercile is associated with a 26.5% relative increase in the percentage of patients who leave without being seen when compared to the median. So to give a concrete example, if your median left without being seen rate is 6%, that would mean an increase to 7.6% on days with low functional bed capacity. This finding is statistically significant and from our fully adjusted model, which accounts for covariates, and it outperformed substituting boarding time, which is the typical metric used. Our study also replicated findings that have been previously shown. We found that larger daily volume, a longer length of stay of discharged patients, fall and summer relative to winter, and weekends relative to weekdays are all significantly associated with higher rates of leaving without being seen. There are no surprises here, but replicating these findings speaks to the internal validity of the study. To review, low functional bed capacity consistently predicts increased rates of leaving without being seen across 3 unique emergency departments in our study. A 26.5% relative increase in rates of leaving without being seen is significant, as this leads to poorer patient outcomes and lost revenue for hospitals. We believe that functional bed capacity is pragmatic and easy for hospital leaders to understand. It can be challenging to internalize, saying, for example, our average boarding time was 271 minutes, but it's easy to frame the metric as our functional bed capacity was 73%. Functional bed capacity is particularly helpful as it's not contextualized by ED size, unlike other commonly cited variables. Overall, it improves our ability to communicate the state of the department. Our major limitation is that we were not able to account for staffing or closed beds in our EDs. The data was not available to us, so we assumed that all beds were open and staffed by nurses at all times. An improved measure of functional bed capacity would not only take into account boarder burden, but would also include closed beds due to staffing. Additionally, there may be unmeasured confounding variables, as with all observational studies, and future studies are needed to speak to the generalizability of our results in other care settings. While in this specific study, we did not assess the characteristics and outcomes of patients who left without being seen, it is something we're currently looking at in a follow-up study. And as a preview, we found that 68%, more than 2/3 of our patients who left without being seen, were triaged as ESI 2 and 3, which highlights the impact on patient safety. So, in closing, functional bed capacity describes the proportion of ED beds available to care for ED patients. It is a simple, pragmatic snapshot metric for hospital and ED leaders. Emergency departments are consistently tasked with driving down rates of leaving without being seen, but increasing throughput alone is not enough. To mitigate the external impact of boarding, we must make the case to hospital leaders to invest in inpatient operations to reduce boarding. Functional bed capacity may be a new way to compare across sites nationally to make sure that we're all speaking the same language when we measure, communicate, and report the impact of inpatient boarding on ED operations. Thank you.
Thank you, Dr. Berlyand.